Polycystic ovary syndrome, PCOS. Epidemiology. Polycystic ovary syndrome, PCOS, is characterized by hypertrophied ovaries with multiple tiny cysts. It is a highly prevalent condition, affecting approximately 6 to 10% of women. The incidence is even higher among Hispanic women, with more than 20% being affected. Additionally, PCOS is more common in women with morbid obesity, with a prevalence of 28% compared to 5.5% in non-obese individuals. PCOS is a leading cause of reproductive and hormonal disorders, accounting for 75% of infertility cases and affecting 95% of women with hyperandrogenism. Etiology/causes. The etiological agents in PCOS development are not fully known. It is considered a multigenic disorder with 3 possible causes: hypothalamic pituitary axis dysfunction, abnormal steroidogenesis, and insulin resistance. Impairment in the pituitary/hypothalamus function increases luteinizing hormone, LH, levels relative to follicle-stimulating hormone, FSH, concentrations, increasing the risk of hyperandrogenism and amenorrhea. Abnormal ovarian steroidogenesis results in higher testosterone levels. Insulin resistance due to genetics or lifestyle affects the receptors and enzymes controlling ovarian androgen secretion, increasing the PCOS risk. Genetic factors have also been implicated in PCOS pathogenesis. Different phenotypes of this disease are linked to genes involved in ovarian androgen synthesis and regulation. Further, genetic variants implicated in insulin resistance, atherosclerosis, and chronic inflammation also cause PCOS in first-degree relatives. Such polymorphisms affect androgen and insulin receptors. The etiology of PCOS also implicates environmental factors, such as metabolic syndromes. Obesity, abnormal BMI due to unhealthy lifestyle, occurs as a comorbid condition in 50% of women diagnosed with PCOS. Insulin resistance is another metabolic syndrome associated with PCOS development. Therefore, the diagnosis of PCOS often involves screening for obesity and insulin resistance in the female patient. Hallmarks or pathognomic signs. The most common clinical manifestation of PCOS is hirsutism. Hirsute women are hairy on the chest, face, and arms/legs, just like males. Hirsutism is attributed to increased 5-alpha reductase activity. PCOS also manifests as acne or facial lesions, hyperandrogenism, deeper voice and muscles, and androgenic alopecia, balding. Other pathognomic signs include menstrual abnormalities such as amenorrhea and infertility due to LH/FSH imbalance. Oligomenorrhea, a condition characterized by infrequent menstrual flow, affects over 70% of women with PCOS. The underlying cause is the enhanced androgen biosynthesis in the ovary due to impaired hypothalamic pituitary function. The metabolic signs or symptoms of PCOS include obesity and insulin resistance, which causes glucose intolerance and T2DM in patients. Women with PCOS also present with acanthasin nigricans, dark skin patches on various parts of the body. Diagnostic criteria. According to the Androgen Excess/PCOS Society, AEPCOS, criteria released in 2016, PCOS diagnosis involves 2 considerations: androgen excess and ovulatory dysfunction. A woman with androgen excess presents with either hyperandrogenism or hyperandrogenemia, elevated testosterone bioavailability. On the other hand, ovulatory dysfunction manifests as menstrual irregularity, amenorrhea and anovulation, and polycystic ovary. The other PCOS diagnostic criteria include the Rotterdam and NIH criteria. A positive diagnosis using the Rotterdam criteria requires the presence of 2 out of the 3 signs: oligoovulation/anovulation, hyperandrogenism, and/or polycystic ovaries confirmed through ultrasound. PCOS is confirmed if a transvaginal ultrasound reveals more than 12 follicles in either ovary that measure 2 to 9 mm thick each and an enlarged ovary greater than 10 milliliters. Correct PCOS diagnosis requires the exclusion of related medical etiologies. The other causes of hyperandrogenism and menstrual irregularity that require exclusion include Cushing's syndrome, hyperprolactin, thyroid disease, acromegaly, obesity, etc. What are the potential benefits of PCOS to the affected female population? Having the PCOS gene confers certain selective advantages to the affected women. It may lead to improved survival during winter or famine due to increased adiposity, i.e., PCOS-related obesity. Further, PCOS lowers the risk of osteopenia and osteoporosis due to insulin resistance, hypoinsulinemia, which preserves bone mass density in affected women. PCOS accounts for over 90% of infertility cases. Thus, pregnancy is not an issue in PCOS patients. What are the long-term sequelae linked to PCOS in women? The primary long-term comorbidity of PCOS is type 2 diabetes mellitus, T2DM. Insulin resistance and obesity are the two hallmarks of PCOS. Therefore, prolonged insulin resistance increases the risk of T2DM development in PCOS patients. Dyslipidemia, abnormal lipid levels in the blood, may occur in obese PCOS patients. Another long-term sequela related to PCOS is endometrial carcinoma or uterine cancer.